Hello, everybody. Welcome to the EMIC webinar. My name, as you can see on the screen, is Andy Greenshaw. I think I probably know quite a few people attending today. It's a pleasure for me to be the host for today's meeting. And we are going to discuss a complex area, challenges and innovative solutions surrounding frequent and complex callers to telehealth services. Individuals' complex needs are difficult within the health system. When you think about them interacting with a telehealth service, that is a high degree of complexity. And the presenters today are going to talk about how we can approach a more tailored, comprehensive approach to ensure the needs of the clients are met while also meeting the needs of frontline staff. We're lucky to be joined by a team of experts working to improve telehealth services and user outcomes, not surprisingly in New Zealand, which I see as the poster child for mental health telehealth services. And you'll hear from the speakers soon. I have a few housekeeping things to deal with first. When you are in the list of participants, you can share your current location or area of interest. You do that by clicking on the three dots next to your name tag, choose edit, and add your country or area. There's not a lot of room, but just something that will allow people to know who you are. And if you have questions during the webinar, you can please put them into the chat, and I'll do my best to include as many of the questions in the discussion time that we have. Today's webinar is being recorded, and soon after the webinar is concluded, it will be put in the EMIC Knowledge Bank so people can have access to it. So it gives me great pleasure today to introduce three individuals who are working with Whakarongorau, their telehealth service in New Zealand. Malik Rizwan, Senior Telehealth Specialist, Product Owner, Valentia Technologies. Dr. Sharon Moore, a clinical psychologist, Service Delivery Manager in the Coordinated Care Team. And Stasha, who's the Analytics and Insights Lead. There will be a presentation with these three together with PowerPoint, and then we'll move into the discussion. So I would like to invite the speakers to enter the webinar now. And here's Sharon. And we should see, okay, it looks like Sharon and our other two guests are there, but Sharon's big on the screen here. I'm going to pass it to you. There's Stasha, and I think probably voice activated. So if Malik says something, he'll probably pop on too. But I'll let the three of you go through the presentation. I think, Stasha, you're going to share the PowerPoint presentation, and I'll pop back in about 30 minutes when you're done, and I'll be watching the questions coming in. Thanks so much.
Yeah.
Thanks, Andy.
Thanks, Andy. And kia ora, everyone. Thank you for coming along to our webinar today. We're super excited to talk to you about this topic and give you three quite unique perspectives on it. So I will kick us off with our presentation and a quick intro. We're just very conscious of the time today, and we want to be able to leave as much time as possible for discussions and questions at the end. So we will go through our intro and our pack as quickly as possible, giving you enough context, but then we really want to leave it up to questions and discussion at the end. So I'm going to share my screen and share the pack that we've prepared. If there are any issues at all, please pop a comment in the chat and one of the team will be looking. I will just find... Great, this should come up. Awesome. Now, Malik, can you confirm just that you can see the presentation now?
I can see it, but there are a few boxes on the right side. I'm not sure if you see that, Sharon, as well.
Yes, I see the same.
I'm sorry about this. I've removed a box. Is that?
Yep,
help?
one is gone, and then you still got one on the bottom right.
Oh, I don't see that. Should we just get started? If it becomes a problem, we'll...
Yeah, let's try.
Cool.
Yeah.
Awesome. Thank you, everyone. So as Andy mentioned before, today we've got Sharon, Malik, and myself. We'll each do a brief intro as we talk through our pack, but I'll kick us off today. So I'm Stasha Ramandik. I'm the Head of Analytics and Insights at Whakarongorau Aotearoa New Zealand Telehealth Services. I look after all things data, insights, and reporting, as the title suggests. I've been with the organisation just over 4 years now, and I work very closely with service delivery managers and operational leaders like Sharon to understand what issues and what pain points we have in the operations side with our customer experience and just efficiencies in general. And I also work very closely with our technology partners like Valentia and Malik to make sure that our systems are set up in a way that we can address these issues through data and actionable insights. So brief intro, and I'll jump into all about Whakarongorau. Andy gave a brief intro on the topic before, so today we're talking about coordinated care strategies and e-mental health, so supporting our callers with more complex needs, how we use technology to address these needs and build a system that enables this care, as well as how we use data and insights to identify opportunities for improvement and also make sure that those opportunities that we end up implementing or improvements that we implement, that they actually work. Whakarongorau, for those of you based in Aotearoa, you may have heard of the name Whakarongorau Aotearoa New Zealand Telehealth Services, but it's more likely that you would have heard of one of our many helplines, including Helpline 1737, Need to Talk, Quitline, and a bunch of others. We also ran COVID support services, which you would have likely heard of and used through the COVID pandemic. We have a video that's coming up that I think will explain Whakarongorau as an organisation and the impact that we make better than the words we've got on the screen. So I'm going to play the video. Let me know if there are any issues, but we also will share this pack for those that are wanting to watch this back.
Kia ora, thank you for calling the COVID Healthline. You're speaking
Welcome
with
to
Maddie.
1737. Kia ora, thank you for calling Healthline. My name is Tim. Before we continue, would I be able to get some information?
Bienvenidos a la línea de salud.
I had severe bleeding, exceptionally more than a regular period. I called Healthline. We went into the ambulance and they helped me through into theatre. It worked really well for me and it gave me the right advice at the right time.
He came out and swabbed me and tested me, and a day later I got a call to say that I tested positive. What was really, really helpful was the COVID-19 helpline. They checked in on me daily, a reassurance and a calming overall that, hey, somebody was out there connecting with me.
I felt a lot of hopelessness, as if being on this earth was quite difficult. I reached out to 1737. The fact that I could text them and not have to speak with them face to face made it less invading for me.
What I found challenging was peer pressure. What I found difficult was all my mates still smoked. I'd had enough. I decided to stop because I wanted to be a role model for my kids.
It was very real and I definitely had no one to talk to. I needed immediate help. 6 weeks for a counselling session just wasn't going to cut it. And the lady who I talked to was just like a godsend.
If I hadn't called them when I did, I don't know how bad it could have gotten.
It's so crucial, not only from a health perspective, but just from a well-being perspective.
That really helped me to hold on that much longer until I could speak with someone face to face with my whānau and my friends.
She basically made me feel like it wasn't too much. She's making me feel like it was really important.
Have you tried to get everyone in the household safe?
Awesome. Hopefully that worked well for everyone. I will now pass on to Malik to introduce Valentia and the support that they provide for Whakarongorau and other organisations. So over to you, Malik.
Thank you, Stasha. Am I audible?
Yes, I can hear you.
Okay, perfect. All right. Good morning, afternoon, or evening, wherever you are joining from. My name is Malik from Valentia, and I look after our telehealth platform portfolio. I'm account manager for Whakarongorau as well. Depending on the topics, I wear different hats. So I have a technical background, but I have some manage some commercial activities in the telehealth space as well. We'll try as quickly as possible to cover in the short time, but I may run a couple of minutes over. So Sasha and Sharon, feel free to stop me if I'm taking too much time. So today's topic, managing complex situations in e-mental health services. Before we dive in, I thought I would give you a quick intro about Valentia and what we do. But first, I guess it's important to acknowledge the partnership we have with Whakarongorau, which has been going strong for over a decade now. This collaboration has been key in delivering telehealth services effectively in categories like population health, mental health, psychosocial support, and clinical care. So this partnership between Whakarongorau as a service provider and Valentia as a technology provider is all about transparency and close cooperation, so that we can ensure that we meet the needs for those we serve. I think today Whakarongorau offers a range of over 35 telehealth services. Is that right, Sasha? And responding to 1.8 million on average contacts yearly, and supporting 1 in 4 people in New Zealand, which is incredible. And together we've been able to make this real difference. All right, so if you're wondering how we manage to deliver such a wide range of services through single platform, can you go back to the previous slides, Sasha? And it all comes down to the telehealth system spectrum that we provide to Whakarongorau, which originally we built to support after-hours services in Ireland. And we still do that. But back in 2015, when we teamed up with Home Care Medical, now called Whakarongorau Aotearoa, National Telehealth Services, we I wouldn't say we customized it. We enhanced and tailored the system to fit New Zealand's unique healthcare landscape by doing things like connecting seamlessly with the National Health Index, which is called NHI, and integrate with eSAM and address lookup from Health New Zealand. And a lot of other things like delivering consult summaries through HL7 on the New Zealand Connected Health, and among other features to have specific workflows and processes. And as an evidence of that, how successfully we did that, we have some stats from Whakarongorau and other clients. As you can see, our platform assisted around 2 million patients across New Zealand through organizations like Whakarongorau, Breast Cancer Foundation, National Poison Center, and others. And this has been, there has been a significant reduction in the emergency department visits thanks to our collaboration with Whakarongorau. Features like video streaming, image upload really help bridge the gap between patients and clinicians in the telehealth setting. And I believe these numbers really highlight how Spectrum is enhancing telehealth services across the country in collaboration with Whakarongorau. Next slide. All right, so just really quickly to share a bit about us. We started back in 2004, and we've been around for quite a while now. We have got a global presence, working closely with our clients across the globe, and who we consider our partners, by the way, in several countries. In the Middle East and Africa, we support some national emergency and mission critical services like ambulance services. On the map, you can see our skilled staff spread across different countries, including Australia and New Zealand, where we have been operating for last 12 years now. Here in New Zealand, we've got a range of products in areas like population health, emergency, secondary care, aged care, telehealth, cancer care. I can't cover all of that, but just to give you an idea, almost everyone in New Zealand interacts with our system at some point in their life. And I just realized that I accidentally cropped New Zealand off the map. Totally unintentional, I promise. Next slide. This is sort of our primary care ecosystem. Excluding the product that Valentia is, Whakarongorau is using. So we've got almost 2 million enrolled patients on our Indici platform, and casual patients are a lot more than that. So Indici is our clinical telehealth platform, which is different from Spectrum that Whakarongorau uses, and is originally designed for GPs, but the product has evolved into a suite of services now. So we handle almost 100,000 consults every year. And we hold 85% of the telehealth market in New Zealand at the moment, working with partners like CareHQ and TEN. And we are the biggest cloud-enabled health provider, informatics providers, reflecting our expertise and experience in integrations, which is required for running large operations like this. And I guess it's all possible through continuous innovation. And we have a strong culture, and it's one of our core values of innovation in Valentia. Okay, so I won't spend too much time on this because there's a lot to be covered by Sharon, but this is a very high-level bird-eye view of Spectrum product. You can see on the left side, I've changed the language a little bit to adjust with the topic, today's topic. On the left, you can see complex callers contacting us through omni-channel, like they can call us, they can text us, video chat, and others. And then you right at the top, you have got the users, case referrers, case managers, or frontline staff can log into the system. On the right side, we've got several integrations. This is really a high-level view of the integrations that we've got in the system. And then in the middle, you can see the system, which has several features, but just few of them are mentioned, like case management, safety, and plan and assessments, dynamic workflows, notification, interaction management, and so forth. Now, I will hand over to Sharon, to kick off today's discussion.
Kia ora, everyone. Thank you for joining us. So I'm going to talk about our coordinated care team, which was established in 2019, essentially to provide better support to service users whose needs weren't being met by our standard service offering. I'm happy to answer any questions in this space at the end. But what I would say is that I guess our system and our service was originally set up to be brief intervention, I guess one-off contacts. And I guess over the years, particularly on the back of COVID, we've seen that the needs of the population have changed. And in many instances, we are the primary support. We meet a range of needs in terms of, I guess, health and mental health. So we've adapted to meet the needs in recent years. Originally, it was anticipated that CCT could provide enhanced support for service users who might be classified as having more complex needs and who may call frequently. It was also anticipated that we might be able to mitigate the impact of frequent and complex callers on service lines performance, but also the impact on frontline staff. So with respect to that, I guess frequent callers have been found to occupy so much time that other callers might have difficulty getting through. So, for example, one Australian study by Spittle and colleagues found that 3% of callers made up to 60% of all calls. Furthermore, other research has found that high frequency calling and high complexity can have a potentially negative and sometimes demotivating effect on frontline staff. Next slide, please. Thank you. And so in terms of the coordinated care team, there was myself as service delivery manager, clinical psychologist, and we also had 2 full-time staff, a senior social worker and a senior occupational therapist who were case managers. And we had the ability to bring individual consults, namely on a Friday to one of our lead psychiatrists. So between us, we were, I guess, a mini MDT. So again, I guess if the next 3 slides are looking at the research and the broad landscape of complexity and frequent callers. So the most common recent definition of a frequent caller is somebody that calls essentially a specific line 20 or more times per month. And CCT adopted this, and this is I guess, a definition that we apply to our data and analytics, which Stasha will talk about soon. We do acknowledge, I guess, that this definition will capture a range of callers with different calling patterns. Interestingly, in the research, most outcome measures focus primarily and perhaps unhelpfully on frequency and duration of calls. And one of the key researchers in this space is Mishara, and I'll put the reference in the next slide, but he noted that there is little or no outcomes research on the benefit to callers. There's anecdotal evidence, as in they keep on calling, so there has to be some benefit, but we haven't been able to tease out what those benefits are specifically. Thank you. Generally speaking, frequent callers, and I should preface this, this particular research by Middleton and colleagues and Spittal is based on Australian research, and off the top of my head, they focused on Lifeline Australia, so it is primarily a mental health consult setting. And so in that context, they found that their frequent callers may use more mental health services because they're isolated, socially disadvantaged, anxious, and they may have experienced more traumatic events. They may call to talk about their mental health problems when feeling lonely, or to seek advice, or to talk about difficulties. Again, Mishara, I guess, addresses quite clearly, I guess, some concerns that frequent callers might not have legitimate needs. And so he says, we do know that frequent callers generally do not appear to be calling for trivial reasons. They often have serious difficulties, including health and mental health difficulties, and they appear to have at least a similar suicide risk to infrequent callers. And that's something that we definitely found on our lines. Again, of interest, I guess, Mishara provides a beautiful, I guess, summary of what different research has found and their recommendations, which are very broad in terms of how lines might best support frequent callers. So those recommendations include encouraging callers to limit their use of helplines, to employ limited numbers of calls a day or limited duration, to assign a specific helper per caller, to create individualized case management plans, to initiate regular contact in terms of the line would provide an outbound call, we would call them, as opposed to them calling us, to involve a caller's social support network, provide brief structured interventions, accept calls without modifying usual practices, provide regular clinical supervision for helpers, and to use paid staff instead of volunteers. Again, Mishara concluded that there's insufficient pertinent research to inform how best to help frequent callers, and each of those recommendations has advantages and disadvantages. So focusing specifically on the coordinated care team and how we, I guess, evolved and the support we provided to service users. So firstly, starting off with engagement. So we would receive referrals. I'll talk about that more in a minute. And we would endeavour to get consent via frontline staff from a service user for us to contact them. That would be done by our case managers. And so through discussion, they would identify what their broad needs are, what they find helpful or unhelpful, their current supports, and what else they might require, very broadly speaking. So there was a very broad psychosocial support. On the back of that, at a high level, our case managers might signpost them to supports within the community, while also identifying barriers that they might encounter to engaging with those supports. In terms of collaboration, we would endeavour to seek permission from a service user to be able to reach out to their existing support. So that might include liaison with their GP, or if they have a clinical team, or family or other supports. And I guess collectively, I guess input and collaboration with the service user and their supports, and also acknowledging that we would be trying to support our frontline staff, we would collaboratively create support plans, which would pop up when somebody called. So the frontline staff would be informed as to how they might best support this particular caller. And Stasha will talk about some research that was done by an Auckland University of Technology student with respect to the impact of our support plans. And then I guess finally on this slide, we would monitor, we would review calls, we would get feedback from service users and from our frontline staff as to whether the plan was working or whether it needed to be amended. As acknowledged at the beginning, I guess the team had a dual focus. Number one, to provide enhanced support to our service users, but equally of equal importance to provide enhanced support for our staff. So broadly speaking, I guess our input extended to a service line managers, people leaders and frontline staff. I'll talk about this in the next slide, but we evolved to providing case consults, which greatly enhance collaboration between our team and each of the individual service lines, because each of them, I guess, based on the services they provide, will have different needs, just like individual service users will have different needs. And broadly speaking, staff felt very much supported through case consoles, but also in terms of the creation of support plans. And so the CCT collaboration with services essentially buffered frontline staff from the potential impact, negative impacts that Mishara highlighted, namely it helped buffer from stress, anxiety and other negative or demotivating effects. Next slide, thank you. So quite quickly, I guess, in terms of the evolution over the 4 years that the collaborative care team was in existence, originally it was anticipated that referrals would be generated from frontline staff, from data and analytics that would highlight service users that called very high or very frequently, and collaboration with people leaders. However, over time, the vast majority, as in 95% of our referrals, were coming from frontline staff. And the impact of that is that we had very high referral volumes, acknowledging all of those lines could refer through to us in terms of frontline staff. Staff were referring on the back of their there was perceived unmet needs, but there was also really, really high complexity and a lot of risk. Over the years, CCT, informed by the research, had trialled a number of different approaches based on those recommendations covered. And one of those areas that we trialled was proactive outbound calling. Our case managers would call frequent callers, maybe 2 to 3 times per week, on some instances daily. There was no fixed duration. We did observe some reduction in service users' contact of frontline staff, as in via the usual channel, but overall it didn't encourage callers to engage with more appropriate supports in the community, and also it was unsustainable in terms of resourcing. Other learnings was that we became quickly aware that service lines rarely support excessive calling limits or call blocking, which we found did not address service users' unmet needs. But equally important, it could result in callers not providing their name. They might change their phone numbers frequently, sometimes every few weeks, and that resulted in them using multiple phone numbers and alias. And the impact of that, and Malik might be able to touch on this, is that it created in the system a whole lot of duplicate files, which meant that support plans that might be put in place didn't pop up necessarily if somebody's calling on a different number. And CCT adapted its approach on the back of these record number of referrals, and we adopted a case consult approach, which I'll talk about next. So the CCT, I guess, case consult approach goes as follows. So frontline staff, if they had a service user they were concerned about, they would flag this with their people leader, who would review whether a case consult was referred to CCT. One of the key differences is that within each of the main teams, for example, Healthline or 17337, the team would identify a main liaison staff member, and so each week, or as required, a member of the team would liaise with that line's team member to review particular service users, and then we would collaboratively, I guess, review calling behaviour using Stash's beautiful data. We would collaboratively create alerts or support plans. And this actually worked a lot better than working in isolation in that siloed sense. So I think that's it from me. If I could hand over to Malik, and just what I would also say is that in addition to meeting the challenges of complexity and frequency, we also encountered some challenges in terms of systems, which Malik will speak to now. Thank you.
Thanks, Sharon. So to connect with where Sharon finished on the process flow, that was really the problem at hand from the technology point of view. Like Sharon explained, the system was disconnected. There was a Microsoft SharePoint form, isolated form to take the referrals, and data was being submitted into an Excel sheet that has a missing link with the central database. There were Teams meetings done that were recorded outside the system. Spreadsheets were then updated for the urgency rating and other things. And a part of that was going back to the Spectrum telehealth platform to take for example, the user's consent or scheduling any callbacks or updating the care plans and so forth. So really, with all that, the challenges, as you can see on the slide, were if I read from the top right on the challenges side, disconnected in manual workflows. So inefficient tracking, no real-time updates meant frontline team had limited visibility on the case progress. And then we had a high referral backlog and delayed interventions due to the number of manual steps. Triage process was slow, leading to the waitlist referrals. Time-sensitive cases lacked immediate intervention and impacting service user outcomes. Then with all that, the fragmented systems with some information going into the Excel sheets and referrals forms hosted on Milo is our SharePoint in Whakarongorau. So team worked across Milo, Excel, Word, Spectrum, creating inconsistent process, and delays were being caused due to that, and critical information was scattered, increasing the risk of missing updates. And of course, all of that causes security and privacy risks. Sensitive patient information stored in Excel sheet and Word document poses privacy and security risk. Manual processes increase the chance of data breaches and compliance concerns as well. Okay, so right, so how did we fix that problem? So we worked very closely with Whakarongorau and to develop an integrated system that eliminated the needs for third-party tools, streamlining these workflows and enhancing their ability to manage cases. So this case management system, again, that system is not just tailored for Whakarongorau, it's scalable and adaptable for other social organizations, government and non-government agencies as well. Some of the key feature highlights that are there. I mean, of course, I can't put all of that in one slide, but referral management got easy. So standardized referral form that was into the system, integrated within the main telehealth platform for consistent data collection, and centralized referral queue to track and prioritize the incoming referrals. And then task, workflows management, ability to assign different flags to the cases, and triaging and categorization. Task and alerts management with the delegation capability, automated notifications and reminder for the follow-ups, and support for the priority based on the urgency and client needs. And tracking, of course, got really easy. So comprehensive profile management with the direct link to the main Spectrum patient record for seamless data access. Centralized notes and timeline to manage the structural history of the interaction. And then, of course, all of that improves the operational efficiency through integrated solution. Now, of course, there is always a room for improvement. So on the right side, you can see some key highlights that are on our pipeline. The first one to move to Azure New Zealand North, that has actually happened this morning. The team was busy since last night to migrate into Azure New Zealand North region. It's a significant milestone for us. We are among the first organizations to move into this newly available Azure environment in New Zealand. And now being in a pure cloud environment, I think we have the opportunity to leverage the native cloud services and drive innovation from there. Things like AI integration, which I should call automation for risk and profile flagging, so that you don't always need a human to manually pick up those profiles that could be complex callers. It could be an automation that. So I'm getting some feedback. So yeah, it could be some sort of an automation that we can do in the system to flag files, so then case managers can review and see which one is right and which one we can use to train the AI for the external referrals, sector engagement, and improve analytics are some other key future improvements on the list. Now, next slide, I have got few screenshots. I won't spend too much time on this, but this is our referral form. Sort of, it's in the Spectrum telehealth system. You don't need to provide the demographics. It saves time. So all you have to do is to provide the service user number, or it could be any identifier. It could be NHI number, and then it pulls the details on the background to be attached with the case. So all you have to do is to provide the specific details that's required for the case, and then everything else gets recorded. So it saves time, and then it's safer from the privacy point of view as well.
We're gonna have to wrap it up in a minute just to give enough time for Q&A.
Sure, Andy. Just really quickly, this is our case manager view. This is a queue where you can see tasks. You can create tasks, set different priorities, risk assessment, and all those sort of things. And the next slide is the detailed view of the case, where you can see the demographic and other features like document media, journal notes, risk timeline, which is a holistic view of patient or service user of their activities within the system among different in different services on Whakarongorau, and other things like behavioral modification program, subscriptions, communication history, and general medical history. Now, with that, I would hand over to Stasha to cover the data parts.
We just have 2 minutes, Stasha.
Yep. I'll wrap this up in 2 minutes, and anyone is welcome to reach out to me in the Q&A or after the meeting as well. So I've just got a quick screenshot from one of our dashboards in this slide. Sharon mentioned before that data and insights are heavily used to inform the approach to frequent and complex callers, but also to evaluate the different interventions that the team implement. So here I've just got a screenshot of one of the dashboards that Sharon mentioned. This dashboard enables Sharon and the team to track overall contact frequency and trends from frequent callers. There are also different views in this that allow Sharon and team to track individual user data as well. So they can look at individual users, how the interventions may be impacting them, the acuity of the contacts, as well as the frequency. And yeah, like I said before, just evaluate if what they're doing is working. We did a quick research study, not a quick research study, we did a research study with AUT to look at different cohorts of complex callers to try and understand the different people being referred to Sharon's team and to understand if the plans are working for the different cohorts of people. So through this research with AUT, we found that there were 4 different groups of complex callers, and the one call out is there was a group of complex callers who less than 50 users, but made up 40% of contact volume from this group of complex callers. So that was a focus for this study. And then the other key finding from this research paper with AUT was that complex caller plans do reduce the frequency of contact from this group of users, and it did actually reduce the duration of contact as well. So that's a 2-minute summary of the data and insights. I'll leave it on the slide that shows our awesome work and the award that Sharon and the team won for this, for the complex caller, the coordinated care team work. And we might pass it over to questions.
Yeah,
Sorry,
thank
that
you
was running through it very quickly.
No problem. Thank you very much. Really good presentation. Very in-depth view. Some questions have come up in the chat, and I'm going to summarize them and push them initially to Sharon. The questions are, what kind of documentation does the consultation team or frontline staff have with regard to clinical consultations? That's from Dr. Zollner. My friend Nina Ferencik from Geneva, wherever Nina is in the world today, has asked, have you tried using AI tools for tracking and managing? And Nina has a supplementary of used AI support to support these callers' client needs for contact and information. One of the things that comes out here is, Sharon, confidentiality is really huge. There's a real limitation. You talked about people changing their numbers, appearing as different people. Do you think it's possible to identify high needs complex callers and push them off to a separate section of Whakarongorau so you had specialized people dealing with complex needs individuals? Have you thought about that? Is that something?
Yeah, so we trialed that for a year or two, and it was very resource heavy, and it actually had unintended negative outcomes in terms of creating dependency, if that makes sense. So I guess largely speaking, in an ideal world, those supports would be anchored in the community where there's funding for those types of supports. What I would also say that I didn't mention is that the team was disestablished around a year and a half ago on the back of funding constraints. So I endeavoured to replace the function of that team, where there was 3 full-time staff, including myself. I endeavoured to replace that level of support 1 day a week. And so I guess the collaboration between the teams, my key liaison person in those different teams is key, so that we collectively, based on feedback from frontline staff and feedback from service users, can create what we now, I guess, refer to as alerts, which or a mini plan, which include, I guess, key concerns, primarily to do with risk. We've moved away from, I guess, our focus on frequency, acknowledging most of the research is in frequency, and we're basically focusing on the very top fractions of a percent in terms of really high risk and complexity, and we're providing a little background overview information for frontline staff. We're providing, I guess, guidance in terms of things like risk management, and we're doing a summary of their current support. So that's in bite size. So we're doing that rapidly based on consultation with our colleagues. And we do that frequently. So for example, on a Friday, I might provide, say, up to 12 individual case consults in terms of individual callers and creating relevant alerts.
Yeah, it's that tension between providing an immediate referral service and some immediate relief and ending up developing a dependent relationship and people coming back instead of being able to push them off. In many parts of the world, one of the problems with this kind of service is there aren't efficient referrals. So you're kind of dealing with them, giving them some stuff and referring them out. And in Canada, for example, which is a well-resourced area, we have massive wait time. So it's a real problem. There are two questions that have come up. We don't have time to look at all of them. Alan Woodward asked a question that relates to what we touched on before the webinar, which is co-creation. How have consumers, those who call frequently, been involved in the development of the coordinated care approach? So in Whakarongorau, do you have a real co-creation thing where you bring lived experience together and talk about how it's working? Comment on that?
Oh, what I would say, I guess, in the original team, there was a lot of scope for, I guess, on a one-on-one basis, creation of collaborative plans, again, on the back of funding constraints. That's not possible. But what I would say, while we do get feedback via frontline staff in terms of a service user has indicated that they'd like this bit of information to be known, we do tailor our plans based on the line. So for example, 1737 is our main telehealth line with trained counsellors, but there's also another line called 1737 peer, which is with peer support workers. Interestingly enough, our peer support line take a majority. They actually take more of our frequent and complex callers than our main line. And so our alerts and plans for that line will be informed by a manager who works in the peer support space. And so the narrative and the wording will be different. So it's definitely a tailored approach for each line.
Yeah, there are some other questions that have popped up that I'm being biased here with my AI interests, but they push it towards the potential for automated systems. There's a question about language barriers. Obviously, we have apps that are pretty good, large language models that can translate quite readily. We had a preliminary chat about this, so this is a question for all of you, and maybe Stasha and Malik, about the potential for implementing large language models to handle some of these conversations.
Yeah, Malik, I mean, I can give a Whakarongorau perspective and then Malik can jump into the Valentia Technologies view. So from Whakarongorau perspective, we are definitely looking at this in a very cautious way. We are running pilots and proof of concepts in areas that are safe. So what we've done is we're looking at the start and the end of the interaction initially. So we're looking at how we can automate some of the data capture, some of the interaction at the very start, and how we can automate and support the tangata whaiora at the end of the interaction and use AI and large language models for closing out the interaction. We are obviously keeping a very close eye on how we can support the clinical triage of the call in the middle part of the call, but we are doing very much a staggered approach and working very cautiously given the nature of our services. Internally, I mentioned before the call as well, so that's our external focus. Internally, Whakarongorau has been doing much more to internally improve efficiency using AI and automation tools. So our support services are using it much more heavily, but we're employing a very innovative but cautious approach externally. I'll pass to Malik to talk about Valentia and their approach.
Yep, I'll pick up two questions from Nina, and you actually made a good point in your second question about using AI to collect the contact or basic information as such, rather than using AI to fully triage the contact, which is not appropriate at this point. We are still learning about AI at the moment. So answering your first question, yes, that's in progress to see how we can use AI as a way to track and manage these high frequency and complex callers. It's a work in progress, and I think it's a complex topic, to be honest. We have ways to automate few of the things, but we are really careful to not use LLMs or AI as such in a way that it can compromise the privacy or information breach, because we are still learning how these different LLMs are working on the back end. So what we're trying to do is, for example, we have connections with all the LLMs. We're not using them at the moment, but we are seeing how by using an anonymized demographic can help us to achieve some of the AI parts or automation out of it. And then we're also seeing how we can use AI offline within our own data centers rather than sending the information outside the data center for processing. So this is an evolving sort of activity which is happening. We are actively looking at the market, how the technology is evolving, and how we can learn to use effectively and safely in the places where it is required to be used.
A question comes up, Malik, and this is for Sharon as a clinician. You know, clinicians make mistakes, and telehealth line workers make mistakes. Machine learning entities make mistakes as well. In my sort of average view of this, I talk to clients, patients, and I say, well, if the prediction is better, would you take a machine or a human? They're both going to make mistakes. And the margin there is that clients say, I'll take the better prediction, I take the better advice. The chance of somebody saying something inappropriate on telehealth line is not trivial. So how do you manage that just on the human side, understanding it will be a problem with large language models, although smaller than is, you know, the kind of hyperbole in the public media. But how do you manage that? How do you monitor the integrity of the support conversation with somebody in your telehealth service?
So what I would say is that we have a dedicated quality team who systematically review calls and go through, I guess, our internal expectations and high standards. And I guess in instances where a particular call did not meet the mark,
is it a random sampling approach you take?
It's about the random sampling, but also it could be triggered by frontline staff raising an internal incident, or it could be, I guess, feedback from a service user. So it's a combination, and then I guess there I guess it is an impartial review, and then on the back of that there would be training and coaching in terms of maybe the individual caller, but then I guess if there's patterns of challenges, then that might result in team education, for example.
Yeah.
Just to add on that,
Wendy. Just before we go there, Malik, there's one question that comes up, which is actually very sensitive for telehealth generally, and that is, how do you manage consent? You have someone on the phone, they may be under the age of majority. Child or youth may be obvious from some perspectives, so you may have an adult. How do you handle that? What's the formal rule for you?
Yeah, so I guess what we have really clear risk management. I guess that would be our, health and safety and risk management would be a primary concern. We are really aware of finding that balance between being able to share concerns, maintaining privacy. But I guess if it hits a certain threshold in terms of a frontline staff member having concerns, they can seek advice from a shift supervisor in the first instance. While we would, I guess, if we felt that person needed additional support to manage risk, we might look to link them in with an external service. Ideally, and where possible, we would absolutely seek consent. But we do have processes in terms of what we call break glass, where we have to notify, for example, emergency services, police, ambulance, without consent. And what I would say, I guess my role currently is probably more focused on the fraction of the percent of really high risk activity, which includes very vulnerable young people. We would send reports of concern through to one of our organisations, Oranga Tamariki, which is a national service in terms of care and protection of children, in addition to police. So we land that information where it needs to be.
Yeah, a related question from Philippa Butt is, are clients aware that you're building a plan for them or that you're keeping information in a file? How do they get to know that?
In terms of the original time, a referral would have come through from frontline staff, and then we would have gotten consent via frontline for us to call them. So they would have been.
So it's a supplementary process then, really.
Yes. What I would say now is that I guess Malik might be able to talk to this. I guess we can view information that comes through in a particular phone number. It may or may not have somebody's NHI, and generally the notes we put now are just a summary as an FYI to staff. I actually wouldn't call them support plans unless I wouldn't call them support plans unless a service user.
So it's just a flag about what was known from last time.
Yeah, where support plans have either been informed by a service user or have been shared by an external clinical team. Yeah.
Yeah, I think it may be the last question for you. We may have a few more, but Malik, in terms of you know, how information is collected, New Zealand is the poster child for telehealth and mental health, as far as I'm concerned. Fantastic track record. You do amazing work, best in class so far. New Zealand's small. From a tech company side, how do you move to a large, let's take a European nation or an Asian nation that has a large population? How could this be managed? It's very labor intensive, the number of people you'd need, and I'm kind of pushing you into a tech application question, is not so subtly.
Yeah, you're quite right. It's New Zealand is small, but we have seen the time during COVID when we had more than 3 million or 4 million, if I'm not wrong, Stasha, contacts that we were dealing with. We had hundreds and thousands of people using the system at the same time, and the system was processing hundreds and thousands of contacts on the daily basis. So you can take that example to any other country of the same size or a slightly bigger size, to be honest. But of course, you can't have that system that was built 10 years ago to work in 2025 or in next 5 years. So we are continuously improving and innovating in this space, how we can improve the system with the changing need of the technology and the community as well. And an example is that when we started, we integrated with web chat, SMS, and emails, voice, of course, but now it is talking to social media platforms as well. Like, I mean, people can contact you through WhatsApp or other platforms, which is, a certain age group is always on those social media, and they feel more comfortable to contact through those social medias rather than using an obsolete, I would say, medium, which is SMS. So yeah, it's depends how you take it. Like, I mean, there's always a need for innovation all the time, but we have evidence of system and this whole model, including Whakarongorau, working in a very pressured sort of a situation where we had to deal with an emergency sort of situation during COVID times.
Yeah, there are two questions that came up, and one from Dr. Zollner. Alberta, where I am now, it's about the size of New Zealand. Couldn't we do this in Alberta? I think the answer is yes, with the resources and modeling what you do. And it relates to another question I know a tiny bit about in terms of the answer. This is, how are you in New Zealand able to launch this kind of innovative program and bring about a culture change with regard to not requiring people to drive around, but being able to connect by telehealth? And I think there was a real desire to do something for mental health in New Zealand, and Anil Thaplio is involved in that, who's now the CEO of EMEC. And I know Andrew Slater is a former CEO who was instrumental in helping to build. It may have a longer history, but I guess you guys were just ready, and it took off, and the public used it because it was necessary. Any other comments about insight into how you bring about that change? Question for everybody. You're all there in New Zealand.
I mean, we got in there early. I imagine COVID would have, for organizations trying to do this a bit later than us, COVID would have really sped things up. I mean, we didn't have the ability to drive across town, whether it was for a mental health appointment or a GP appointment during COVID. So I imagine that would have been a catalyst for a lot of organizations. But I think a big thing is being able to highlight the impact of our services. We've been able to prove how these initiatives have impacted the lives of others, improved accessibility, cut down wait times, and had a bigger impact on the wider health system, which really gets people involved. It gets them excited about this type of work, and it strengthens our argument to keep going for sure. So I think, there's a lot to it. That's just the insights and impact side of it. The making noise in the community about how awesome the services are has really helped us.
And
That's
what I would
great.
just add to that, I guess, in terms of the wider clinical lens, my psychology and other allied health workforce professionals, if they're going on holidays, they will have in their individual patients, clients' plans. In my absence, if you need to reach out to Healthline or reach out to 1737, so even though we're not intended to provide that, I guess, from a brief intervention perspective, we're integral to the entire health system.
Yeah. Well, on behalf of the global audience here, thank you very much. That's been a really inspiring and interesting dive into Whakarongorau and all of the great things you're doing and will do as this moves forward. And if you have any questions in the audience, please direct them through email, and we'll make sure that they get to the speakers. There's been some sharing of information from the speakers already. I've really enjoyed this webinar. Great questions, and thank you very much. We'll see you next time. Bye-bye now.
Thanks, Andy.
Thanks
everyone.
everyone. Ka kite.